Hello, my name is Jay Chaudhary. I'm the director of the Indiana Division of Mental Health and Addiction, and I'm happy to be here today, or here a few weeks ago, I guess, to talk about a few different things. I'm recording this at the end of September, and this being 2020, I just wanted to say that in case anything crazy happens in the couple weeks in between. So. We're going to talk about a couple things today. We're going to talk about the behavioral health response and implications of the COVID-19 pandemic, and also our new state strategy and direction that we've developed at DMHA and hope to use to guide our work in the next few years. So we'll jump right in. Our COVID response was divided into what I would characterize as three phases, and we're still probably in the middle of phase 3. And I think phase 3 kind of leads nicely into our new mission and vision. So that's going to be kind of the flow of the presentation today. So the goal of phase 1, so this is back in March 2020, we sort of realized that there was going to be massive disruptions to every aspect of life. And our mission at FSSA as a whole and at DMHA in particular was to maintain the services that our providers and patients rely on and sometimes rely on to keep them alive. And that had a lot of different aspects to it, and I'm going to talk about a couple of those in particular today. The first is telehealth. I'm sure you will hear a lot about telehealth during this conference, so I won't go into the details about what that means. But essentially, what we had to do was we were dealing with the first set of stay-at-home orders. The state was more or less on lockdown, and there was these physical distancing requirements, which meant that for a lot of our providers who relied on in-person visits, they had to pivot very quickly to providing services through either phone or video or a combination thereof. And we had people at OMPP and DMHA working around the clock for a couple weeks to try to figure out how to make that happen within our systems. And the governing principle behind the initial response was that we would treat and allow providers to bill for services just like if they were in the clinic. And I'll talk in a minute about how that is going to change in the months and years to come. But our initial response was, look, we're going to treat this the exact same. We want to make it as easy as possible on both the providers and the patients. And as you can see with those results, the uptick was pretty remarkable. During the same period of time in 2020 versus 2019, we had over 21,000, almost 22,000 mental health telehealth claims as compared to 335 the previous year. And overall, we had around the same amount of claims. And in fact, around the same amount of services if you were to unpack those claims. Now, what we saw was the actual duration of those services was a bit shorter as people adapted to this new modality of delivering services. But overall, the results stayed about the same. And in fact, there were some positive changes. In particular, on the mental health side of things, our providers reported a much lower no-show rate for mental health appointments. And there's many reasons for that. I think that a lot of our clients face transportation and other barriers, and it's much easier for them to participate in therapy or other treatment from the comfort of their own home as opposed to having to physically go to the clinic. So that was probably the reason for that. So obviously, we are looking into and working with OMPP and our federal partners on what to do next. But I think that the clear takeaway from telehealth is that it is in fact a game changer as far as delivering mental health services to Hoosiers in a largely rural state. And there's many questions that we'll have to answer and that will guide our future plans here, and we're kind of working through those right now. Number one question, ultimately we're waiting on the federal government to adjust their laws and policy around exactly how telehealth should be treated. Once that happens, we can make the necessary adjustments on the state side of things. We have to answer the question of audio only versus audio video. Obviously, audio video is a much preferred modality because, especially when it comes to mental health, when you're talking about, seeing somebody's face and reading their facial expressions, and that's harder to do as you are just talking to somebody over the phone, but that has to be balanced by the fact that a lot of our clients don't have access to video conferencing capabilities. And so, we have to figure out what kinds of services are okay for just audio only versus what has to be audio video if in fact it's done remotely. Kind of a related issue to that is that we know that there's some types of therapies and visits that really should be done in person. And so while we want to allow and encourage telehealth as much as possible, we need to figure out how to encourage some continuation of in-person visits, whether that takes the form of a ratio or some other way to encourage that. We're still figuring that out. There's billing issues to sort out. One of those issues is what do we do about the issue of facility fees? Under the emergency, we were allowing facility fees to be billed just the same as if the person was there, but obviously on a long-term basis, we can't really allow for the same facility fees when the facility is in fact not being used. So we have to figure, at the same time, there are costs associated with maintaining telehealth infrastructure, so we have to figure out what to do there. And then finally, in terms of quality control, we have to really, really step up and assist each other. So not only does the state have to assist providers, but providers need to assist each other in figuring out what changes and what best practices need to be adopted to provide quality services through telehealth and telemedicine. So telehealth was one adjustment we undertook in phase one, and another adjustment was with our opioid treatment programs. For those of you that don't know, opioid treatment programs are also known as methadone clinics, and they dispense medication called methadone, which is used to treat opioid use disorder. Methadone is a full opioid agonist, which means it binds to the opioid receptor and prevents withdrawal and cravings for opioids. It's the oldest medication for opioid use disorder, and it's very heavily regulated. It normally can only be dispensed in a methadone clinic setting once people demonstrate that they're able to handle it for a while. The current law and regulations allow very limited take-home amounts. And so when we realized that we didn't want people lining up outside methadone clinics or crowding inside methadone clinics to get their doses, we were the first state, before even SAMHSA acted, to modify those take-home amounts that we could dispensed due to the public health emergency. Immediately, most patients were eligible for 28 days of services, and then another subset were eligible for 14 days. We included naloxone, which is the overdose reversal drug, and lock boxes with the take-homes just to increase sort of our safety and also promote harm reduction and save lives. As a result, we've issued over 55,000 take-home modifications and have had very few issues. Just like we suspected, the vast majority of people were fully compliant with all the medical requirements, and so we're discussing, what it would take to make those modifications permanent, at least within the parameters of the federal law. So phase one was responding to the immediate need to maintain services. Phase two was the response to the increased need for behavioral health supports, both on the addiction and mental health side. And again, at DMHA, we did many things. I'm going to talk about a couple of them today. So the first one would be Be Well Indiana, and in particular, the Be Well Crisis Helpline. So Be Well Indiana is the name of the website that DMHA and FSSA launched in response to the pandemic. It contains curated resources for mental health and wellness. It creates links to access those resources directly. It is a kind of a one-stop shop for Hoosiers experiencing mental health challenges, both pre-pandemic and during the pandemic itself. And we did this in response to pretty alarming reports of a very drastic increase of mental health challenges caused by the disruption from the pandemic. So the Be Well Crisis Helpline is what we branded our crisis counseling program, which is a grant program from the federal government. And as you can see, it actually is 2 different grants, and the upshot is it's going to run through the end of June 2021. We hope that it can serve Hoosiers throughout the duration of the extreme mental health crisis caused by it. So just some facts about the Be Well Crisis Helpline. It is accessible through 211. As you probably know, 211 became a division of FSSA on June 1st of 2020, or I'm sorry, July 1st of 2020, and will be fully integrated within FSSA by January 1st. So that was nice timing here because we were able to make this accessible through 211. It's available 24 hours, 7 days a week, and it's a staff of 36 trained crisis counselors available to handle crisis appointments. These are the data from the launch of the program to September 20th, and this includes ramp-up time. So we didn't have all 36 counselors hired and in place by then. And so as you can see, there are over 2,000 calls. The average length of the call was a little over 20 minutes, and over 729 hours our folks spent engaged in crisis counseling. About 41 of the callers had pre-existing trauma or SUD or mental health issues, and which I think really illustrates the fact that not only did the pandemic create new mental health issues, it also exacerbated existing ones. As you can see, the age ranges there. I think more than half were between 40 and 64, and a quarter were between 18 and 39. And only about 17% were over 65, and we are working with outreach to seniors to see if we can get the word out to them a little bit more, because I think, as we know, the stress of the pandemic doesn't really know a difference between people of different ages. And interestingly, about 15% of the callers so far have indicated that the financial stress caused by the pandemic was a reason for the call. Over half of our callers received a referral for additional mental health or SUD services, or made a request for additional crisis counseling services through Be Well. Many of our callers have, in fact, been repeat customers, calling 2, 3, 4, 5 times. And interestingly, only a little less than 2% of our calls were critical in nature, so requiring a 911 dispatch. And we were actually pretty happy to see that, because ultimately, if for critical calls requiring a 911 dispatch, we want people to call 911 directly. And so we think we're reaching the right type of people, the people that are sort of pre-crisis, that need, pre-extreme crisis that need an intervention to hopefully prevent them from getting through that crisis. So as you can see, the different types of reactions, I think these are, very interesting, and it kind of runs the gamut in all of these. I mean, obviously people were able to choose as many as they wanted, as this adds up to way more than 100%. But isolation, withdrawal, fatigue, intrusive thoughts, anxiety, sadness, sleep issues were all significant factors reported by people calling on. So spread the word. In order to access the Be Well Indiana helpline, all you have to do is dial 211 and press option 3. So the second piece of what we did in response to an alarming increase in both SUD and overdoses was significantly expand what we call the regional recovery hubs. So this is part of the Indiana Recovery Network. And the operating philosophy behind this network and this expansion is that the opposite of addiction is not sobriety, it is in fact connection. And this was a time, and it is still a time, where connection is a little harder to come by. And so we wanted to launch what we're calling an army of peers to reach out to folks that are dealing with both mental health and SUD challenges around the state. For those of you who don't know, a peer or peer recovery coach is a person with lived experience that is trained to help people navigate their own recovery journey. So as you can see, these are the goals and objectives, and we are sort of still working on all of these, although I think we are live, and I'll show you those numbers in a minute here. So not only do we want to provide an infrastructure for delivering the community-based peer support, we also want to strengthen the statewide recovery infrastructure and create these regional recovery hubs to localize recovery. and expand access to all kinds of recovery supports. One thing we're working on is how do we build civil legal aid or other recovery supports onto these regional recovery hubs, and also focus on the life-saving MAT, MOUD, and naloxone for populations that are a little harder to reach. So as you can see, it's a very robust partnership involving all kinds of different partners, and we're very excited. And it's broken into 16 different hubs, as you can see here. Central Indiana, in particular, has 4 different hubs. And these hubs are intended to be kind of one-stop shops for folks in recovery, to provide access to peers, access to other support services, and just kind of a safe place, both in person and virtual, for people to go if there are interested in recovery or early in their recovery journey, or even if they're longer into their journey and they're struggling. We want these to be safe places for them to go. And so again, just like with the Be Well Crisis Helpline, we were able to integrate this into 211, and that's been a really good resource. Again, you don't have to memorize another number or another website. You just dial 211, press option 6, and you'll be connected with a person in recovery who's there to help you. And those, as a kind of on the flip side of it, the peers that we are training through this program are also familiar with the resources available through 211, and will be able to help people navigate that system as well. So as you can see, the uptake of this has been very encouraging. Each month since it launched, around the middle of May, we've doubled or more than doubled the amount of people that are using it. As of this recording, the numbers for September were not in yet. So finally, phase 3, and kind of the phase that we're in right now, is is the conversations about how we adjust to the new normal, the new world that we live in. I think I think we're very much figuring it out, but I think that we need to keep and retain as much flexibility as possible while getting rid of unnecessary barriers. As a state and as a system, we've done a lot of things really quickly because we were able to get barriers removed to making that sort of change. And so we really need to examine what those barriers were and if it makes sense to just keep them on the sidelines. And we have to continue to build and integrate and remember that we serve people and not funding streams. I think the person-centeredness of the response by FSSA and DMHA was really an amazing and key to our success. And then I think we need to continue to take that philosophy on into the future. And so that brings me to the final part of this presentation, which is to explain the other thing we did during the pandemic, which was launch a new vision and mission at DMHA. And so our new mission, our new vision, is an unyielding focus on promoting and supporting the mental health and wellness of the people of Indiana. So what that means is, above all else, we try to do what's best for the people we serve. And that's really helpful and has been helpful during the COVID times, because there's a lot of noise surrounding the decisions that we make at the state and how we operate and oversee our programs. And what our vision is to us is a reminder that ultimately we need to figure out what we think is going to be best for the people that we serve and act accordingly. And we hope our new mission helps us do that. So our new mission is to champion mental health promotion and substance use disorder prevention, treatment, and recovery systems that are high quality, seamlessly integrated, and accessible to the people and communities of Indiana. And so as you can see, we've pulled out of that 3 core principles for the systems that we oversee. And those are high quality, seamlessly integrated, and accessible. I'll talk about each of those in turn. So high quality is obviously a huge catch-all type of term, but here's a few things that for us, what it means. Number one, it needs to be person-centered and driven by the individual receiving services. Again, we serve people, not funding streams. So, we need to be able to have a system that tailors interventions and treatment to the person that is receiving them, and not try to fit people into pre-existing holes. A high-quality system is also data-driven. We have a lot of ability at the state now, thanks to the initiatives promoted by FSSA and Governor Holcomb with the Management Performance Hub, to use data to drive our decisions in something close to real time. And so we, at DMHA over the next few years, we're going to work towards doing that. High quality programs are also evidence-based. I think that we need to make sure that the latest research and evidence in our fields are incorporated into the treatment and systems that we oversee. And then finally, high quality care is culturally competent. People don't leave the other parts of their life behind when they come into a clinic or another treatment setting. And high quality care will respect and adapt to a person's specific cultural experiences, I think that the data sort of bears that out. Another piece of this is that we want systems that are seamlessly integrated. So one thing we know about mental health and SUD is that it touches on so many different areas of life, and so we need to make sure we have strong partnerships with all those areas, whether it's courts, the Department of Child Services, the criminal justice system as a whole, schools, other places where mental health and SUD are seen and treated. We also, within the continuum of care that we oversee, we need to make sure that there's smooth transitions. Again, this goes back to being person-centered. If a person all of a sudden needs a different level or a different type of care, we need to be able to ensure that they're able to access it without too much trouble. We also need functionality across and throughout payer sources as much as possible. I mean, there's going to be some bureaucracy and some red tape that holds things up, but as much as possible, again, people don't really care about the trouble on the back end. They just want treatment that is in line with what it is that they need, and they don't really want to care about, like, well, actually you need to access this payer source or whatever. And I think that providers want the same thing. And so as much as we possibly can, we need to integrate all of our programs with all the payer sources that exist. And then finally, I think we have a lot of different populations that we are responsible for at DMHA that are also the responsibility of somebody else, and we want to make sure we connect connect to make sure that those shared populations are taken care of, in particular the intellectual and developmental disability population, who right now are not, folks with intellectual disabilities and developmental disabilities that also need mental health treatment are not getting what they need, and we need to make sure. And then finally, and probably most importantly, we need a system that's accessible, and I think that not only accessible to patients, but also accessible to providers that want to participate. And so as part of that, we need to reduce the administrative burden and reduce the redundancy and red tape that providers have to go through. We've heard many stories from people in the field about how they got into this job to help people, and as it turns out, they are spending more than half their time filling out paperwork, and paperwork that sometimes is redundant. So we're launching a deep dive effort to see what we can do to reduce and minimize that effort. And then on the patient side, we need to make sure that the wait time for services is as minimal as possible, because when people need mental health care and treatment, they need it now, not 6 weeks from now. And we're looking into ways that the telehealth and technology revolution of the last 6 months can help us do that. And then finally, we need a completely transparent system. This is a public system. This is taxpayer money, and we need to be as transparent as possible as we move forward with some of these changes.